Evet, ben de size tekrar dediğim gibi gebelikte anksiyete bozukluklarıyla ilgili mümkün olduğunca
Well, I will talk about anxiety disorders in pregnancy, and I will also try to talk about our clinical experience. I'm going to touch upon epidemiology. I'm going to talk about the impact of pregnancy on anxiety disorders, the impact of anxiety disorders on fetus, antidepressants and fetus, and treatment decisions and options. Of course, these two topics will be handled in a more detailed manner when we talk about treatment options. When we talk about problems in pregnancy, we always ask this question whether pregnancy by itself will increase the possibility of mental disorders. When you look at of course, we don't have enough controlled trials where we compare unwanted pregnancies with wanted pregnancies. Of course, there are some comparative studies that we can take a look on. Unfortunately, there are a couple of psychiatric studies on schizophrenia, but we don't have anything on anxiety disorders. Of course, there are some general population studies, and when you make a general comparison, you see that of course, there are some 20-fold differences sometimes, but in pregnancy, we see a relative consistency in terms of frequency. When you look at apart from OCB, you know, the pregnancy levels are not that different from general population. For OCB, you know, the frequency or the prevalence is a little bit higher in pregnancy than general population. 45% increased risk is proved for the risk of OCB in pregnancy compared to the control group. But for the other disorders, we don't see a significant difference. The second question is, what is the course of pre-existing anxiety disorders? Of course, answering this question is quite difficult because there are few studies and methodological problems with these studies, and there is limited data. Most of them are retrospective. They are all based on the memories of the patients rather than prospective follow-ups and valid instruments. And we have limited data on symptoms of PTSD and generalized anxiety disorder, and limited data suggests that these symptoms may decrease during pregnancy. But panic disorder and OCB are the most researched areas, but these are all retrospective studies. And, you know, pregnancy shows a neutral result when we look at all these studies. And 70% of the time we see that the symptoms do not change or they get better. But when we see patients who want to become pregnant, or when remitted patients become pregnant, of course this information will play an important role. Let's take a look at the effect of anxiety disorders on pregnancy. When you look at the general literature, you see that general stress and anxiety will play an important role, and then we can talk about specific data. There are many studies, and we don't know how much of a risk increase we're talking about here, but we see poor eating and secondary problems to poor eating, poor medical care, alcohol and substance use might increase, There are social and occupational problems. Diabetes and hypertension or high blood pressure can be triggered, and they are harder to control, and ablastio-placenta risk increases nearly twofold, because this increases the risk of the fetus and you have to have a C-section, emergency C-section. Okay, let's take a look at the fetus, and we will look at the perinatal period as well as childhood. There is an increase in placental blood flow resistance. The trials are not that clear. There are some contradictory data, but some trials suggest that there is an increase in placental blood flow resistance. So this results in developmental problems for the child. Preterm and SGA birth, we have somewhat consistent data, and there are some sleep and feeding problems. In childhood, the most consistent data is about school children. They will have attention, cognitive and behavioral problems, and they will also have emotional problems. When you look at adolescents, we see that the psychopathology risk increases when the mother is stressed or depressed during pregnancy. Regarding specific diagnosis, we have very limited data. We have a couple of studies regarding panic disorder. Uğuz et al. Conducted a study back in 2006 in a country that I don't remember now. This was a huge database study, and they found out that panic disorder increased risk of congenital malformation and smaller birth, and maybe anti-panic treatment can prevent this malformation or can decrease this risk. But of course, this needs to be confirmed by other trials in order to treat panic disorder within the first trimester. Anxiety disorders may be related to this, but when we talk about psychopathologies in pregnancy, we usually talk about depression. We don't have any comparative data, but the teams in Konya and Bakırköy suggest that panic disorder has an effect on the birth weight, and its effect is much worse compared to depression. Compared to the controlled group, it's nearly 700 grams, and compared to depression, it's 300 grams lower. Another question is, do the anxiety disorders affect the physical development of the child, or do they also affect the neurodevelopmental systems? We don't have any data at hand, but there are some neuroimaging studies, but they are mostly focused on depression. We have a new trial, but it's not published yet. The maternal OCB is related to higher levels of TNF-alpha in the cord blood. It's like 6 times higher. And in another trial, this has just been published this month, maternal GAD during pregnancy and fetal brain development. This is a comparative study on cord blood brain-derived neurotrophic factor levels. So they go down in the mother's blood, so it's passed from the mother to the baby through placenta. But when you look at animal models and human models, BDNF and TNF-alpha, especially within the last trimester, are not, the mother is not predominant in regarding these two systems, but they are very important in the natal period. And when you think about the possible systems of schizophrenia, maybe this can increase the risk of developing schizophrenia in the baby. Okay, let's talk about antidepressants and the fetus. This is the first thing which pops in our minds when we talk about treatment in pregnancy. And the first thing which pops up in our minds is congenital malformation. Studies mostly include SSRIs. Unfortunately, there are no trials regarding newer drugs and tricyclics. But the studies show inconsistent results. Maybe it's due to the methodologies they employ, and most of them are database studies. And you don't know whether the patient used the drug that was prescribed to her, or how long she used, or what is the severity of the depression or anxiety. These are not clear in database studies, and there are other co-founders, like the economic status of the patient, and these data are not analyzed. But we can say that the absolute risk elevation is either absent or minimal. When we say absolute risk, is what we mean is the malformation risk is evident in pregnancy anyways. And when you put it in 100 of percentages, the percentage is negligibly small when you use antidepressants in pregnant women. Regarding paroxetine and fluoxetine, the data created some concern within the last years, but regarding cardiovascular risk, you know, the prevalence is only 2 to 3, not 2 to 3%. And if this is increased in 2 folds or 3 folds, it's only 0.6% in this patient population. So we can say that the absolute risk increase is quite low. There are 2 meta-analyses regarding malformation risk. This was published in the last months. And fluoxetine and paroxetine should be avoided in the first trimester and among those at risk of an unplanned pregnancy. That's the conclusion of this meta-analysis. Of course, the information is changing very rapidly. 10 years ago, we used to say that fluoxetine was very reliable, but the latest data creates some concern. In terms of cardiovascular risk, the other drug has a risk increase of nearly 40%. Regarding fluvoxamine, there are not many concerns, but we have very limited data, so I cannot reach any conclusions. This is another meta-analysis which was published in the previous months. When you look at the cardiovascular risk, it's increased 36% when you use an antidepressant. When you look at paroxetine, the cardiovascular risk increase is around 43%. Congenital malformations, this is interesting because these meta-analyses include some trials and exclude some others. As you can see, the difference is not significant. Regarding fluoxetine, regarding congenital malformation and major malformations, there is no significant decrease, but it says that it is significant when all studies are included. When you look at more robust studies, you see that there is no significance. Last 5 minutes. So there are some concerns regarding fluvoxamine. We know that in terms of cardiovascular risk, paroxetine is proven. And regarding the new drugs, we don't have a lot of data. Is it only congenital malformation we need to be concerned about? No, there are other effects. Maybe old data regarding preterm birth is quite robust. Antidepressant dose, longer and third trimester exposure may be associated with preterm delivery. And another consistent information is that risk increase is independent of the impact of depression, especially SSRIs. Low birth weight, the data is quite inconsistent, but we don't know whether it's independent of the impact of depression. Regarding pulmonary hypertension, there is a recent systematic review. It's either a small association or no association. Neurodevelopmental problems, there are some concerns in animal studies, but clinical human studies do not show any concern. Postnatal adaptation syndrome has a prevalence of 30%, but the good thing is that the mortality risk has not been reported yet. So it's self-limited and it can get better in a couple of days. What about the treatment decision? Of course, we start treatment if the non-treatment risk is higher. So what are the signs for that? We have to look at the clinical picture of the mother. So we have to think about the mother rather than the baby. Of course, we're not going to risk the life of the baby, but we have to treat the mother, and we will try to use the best treatment option for the baby. So there are possible indications for pharmacotherapy. The presence of a serious disorder calls for a pharmacotherapy because it's going to cause a lot of occupational and social problems. And if there is presence of severe weight loss, like 20-30 pounds, because this can create metabolic problems, and the existence of high suicidality risk, or the existence of gestational diabetes or high blood pressure. And the existence of a temporal relationship between the onset of intrauterine growth restriction of the fetus and the onset of maternal psychiatric problems. Regarding the treatment options, we don't have a guideline. We don't know what we're going to do for which patient. There are no guidelines. Of course, there is a consensus. The treatment has to be personalized for the patient. What I recommend is that if it's a mild or moderate anxiety disorder, we could apply CBT and psychoeducation. If it's a severe disorder, or maybe if it's mild and moderate depression, we don't know treatment will give better outcomes than no treatment. If the disorder is quite severe, we have to go for pharmacotherapy as first line. If it's moderate but comorbid with mood and other anxiety disorders, then we have to start medication. If it's moderate but there is a history of inefficacy or incompliance to CBT, then we have to put the patient on medication. As you know, psychoeducation is very important. We have to inform the patient about the risks and benefits of the treatment and no treatment. The patient still has the core symptoms of anxiety. She has concerns about pregnancy. She is concerned about the health of the baby. She wants to discontinue treatment. It's like a double-edged sword for the patient. She doesn't want to terminate the pregnancy, so she's in severe anxiety. You have to put the patient's mind at rest, otherwise it will be very difficult for you to alleviate the core symptoms of anxiety. So this is what we have to underline in psychoeducation. We have to relax the patient because the absolute risk is not very high. The patient should know that the pharmacotherapy can be started when the doctor thinks it's necessary. And she has to feel confident that everything will go well. And some patients really benefit from psychoeducation. Of course, we're going to look at the patient's history. We're going to use a single drug and with the lowest possible dose. For the AD options, SSRIs are our first-line agents. Sertraline and citalopram are safer SSRIs. Paroxetine is not a first-line choice, but if the patient is a non-responder to the other SSRIs, then it can be administered. And venlafaxine is a second-line drug. If you use higher doses of SSRIs, then the preterm delivery risk increases fourfold in some studies. When we say high dose, for example, for sertraline, it's 100 milligrams. For most of the other drugs, it's 40 milligrams and higher. And our clinical observations show as much. For Turkey, it's even 50 milligrams, not 100 milligrams for sertraline. So especially in OCD, we have to be very careful about pharmacotherapy. We should avoid high doses. And there are some patients who has lost a lot of weight. They have sleep problems. So SSRIs will not work on these patients. We can use low-dose mirtazapine between 7.5 to 15 milligrams daily can be used for these patients. And starting from the first day of administration, the nausea is fixed, the patient's appetite is restored. And if there is no comorbid depression, maybe we can use low dose of imipramine between 10 to 50 milligrams. We're using it for 50 or 60% of our patients. As you know, it's a potent drug for panic disorder, and we know that it's quite effective in lower doses. It can create some neonatal convulsion risk or cardiovascular teratogenicity risk. So there's a question mark here, but these are for depression doses. We don't think that 10 milligrams will create those problems. CBT is a non-pharmacological treatment. We know that it has a good effect on anxiety disorders. For mild to moderate anxiety disorders, it should be first line, and we think that it's going to be effective in pregnancy. That's what we expect, but there are no trials showing that it's effective in pregnancy. And how far can we go for pregnant women? And we need exposure in CBT and the anxiety will increase, and then it can have a bad impact on the fetus. We don't know what's going to happen, and till we can relieve the symptoms, maybe it's going to be a long time till the symptoms are alleviated. So maternal anxiety can create an adverse effect on the fetus, and we don't know whether CBT has a protective effect on the fetus. So anxiety disorders are not rare in pregnancy. Antenatal anxiety disorders have several adverse effects on perinatal and developmental conditions. Although the antidepressants have some risks, these are very low. And for severe cases, these are still the gold standards for treatment. But of course, it all depends on the mother. But as clinicians, we have to give them the right information. So we have to help the patient make the right decision. So they will be either exposed to antidepressants or will be exposed to the illness. And in determining the treatment, we have to look at the mother, because if the mother cannot get well, the baby will not be in a good condition anyways. Thank you.